Deep anterior lamellar keratoplasty is a technique used for replacement of the diseased anterior layers of the cornea while preserving a healthy descemet and endothelium. This procedure is preferable to penetrating keratoplasty for ectatic diseases and stromal opacity with normal endothelium, because it avoids the risk of endothelial rejection and is performed in a closed-eye system, minimizing intraocular complications like in this case of endophthalmitis. On the other hand, it may be time-consuming and technically demanding. Manual lamellar dissection techniques leaving stromal tissue often result in suboptimal visual outcomes due to interface irregularity and haze, as seen in this patient. Complete removal of the corneal stroma, leaving a bare descemet, is desirable as it provides excellent graft interface quality for better visual results. Different DOP techniques have been described, including direct open dissection, intraestromal air injection, hydrodomination, viscoelastic dissection, and more recently the big bubble technique. The purpose of this video is to describe an innovative technique for intraestromal air injection to achieve DOP with bare descemet. After a 400 micron trephination, intraoperative corneal thickness measurements using ultrasound pachymetry are taken 0.8 mm internally from the trephination groove in the 11 to 1 o'clock position. In this area, a 2 mm incision is made parallel to the groove with a micrometer controlled diamond knife, calibrated to 90% depth of the thinnest measurement. The incision is opened with fine-tooth forceps and widened superficially with a 15-degree blade. The deep stroma is exposed, and an initial dissection is carried out with a delicate iris spatula, close to the descemet membrane. A tunnel is then created with a dog spatula from this initial dissection plane until it reaches the central cornea. To inject the air in the deep stroma, a 27-gauge cannula attached to a 3 ml syringe, filled with 0.5 ml of air, is introduced deep into the tunnel. Air is injected until a medium to large size bubble is formed above the descemet membrane. Subsequently, a limbo paracentesis is created using a 15-degree blade at the 11 o'clock position to remove a small amount of aqueous and lower the intraocular pressure. Anterior keratectomy is performed with a crescent blade, and a small amount of viscoelastic material is injected inside the bubble to keep the descemet away while an iris spatula is inserted through the hole. Next, the hole is enlarged with a 15-degree blade, and the iris spatula is used to dissect the stroma from the descemet in the periphery of the bubble to reach trephination borders. The rest of the stromal tissue is divided into quadrants, each one completely excised, bearing the descemet completely. The donor cornea is placed in the punch block, and trypan blue solution is applied to stain the endothelium. The descemet and the endothelium are completely removed with untoothed forceps, and 0.25 mm oversized donor cornea button is punched out. A superficial 400 micron trephination is performed. Ultrasound pachymetry measurements are taken 0.8 mm internally from the trephination groove. A diamond knife is used to make a 2 mm incision calibrated to 90% depth. The incision is opened and a tunnel is created with a dog spatula to reach the central cornea. Finally, a 27-gauge cannula is used to inject air deep into the tunnel, detaching the descemet membrane. Other examples of the Pachy-Bubble technique are illustrated. We have performed this technique in 30 eyes with keratoconus, and so far our success rate of Descemet detachment by air injection is 90%. All cases but one required a single air injection to achieve Descemet detachment. In 2 cases, the Descemet had to be bared by manual layer-by-layer dissection. After air injection, failed to detach it. Only 1 case was converted to penetrating keratoplasty. All others have bared Descemet down. In this interesting case, after air injection, the bubble is barely visible. The bulking of the anterior stroma reveals a small-sized bubble of Descemet detachment. Viscoelastic material is injected inside the bubble, and surgery is carried out without complications. It is interesting to note that in most cases, after air injection, the anterior cornea stays relatively clear and does not assume a diffuse whitish appearance, what is frequently observed when air is injected superficially. We have used successfully the Pachy-Bubble technique in other cases, including Salzmann nodular dystrophy, corneal scars due to herpes, corneal dystrophies, and after radiokeratotomy. Overall, our success rate has been over 90%. When going through the trephination with a needle, frequently air injection is shallow or in the mid-stroma, and it spreads laterally inside the corneal lamella without attaching the Descemet, like in these 2 cases. The surgeon may try deeper air injections or switch to the conventional layer-by-layer dissection, which may lead to perforation when trying to remove all stroma. Deeper trephinations may facilitate needle insertion near the Descemet. However, they may result in perforation, especially in thin corneas like in this case of advanced keratoconus. Exact depth control of the groove is difficult with suction trephine. There is great variability in corneal thickness around the 8 mm trephination zone, especially in cases of keratoconus. Another challenge is to reproducibly insert a sharp needle very deep into the stroma close to the Descemet without perforating it. In conclusion, Pachy-Bubble technique is safe, easy, with a short learning curve, highly reproducible, and has shown superior success rate.